Hello, everyone. I'm Rose Gerber, the Director of Patient Advocacy and Education for the Community Oncology Alliance. Thank you so much for joining us today. You can see that we have a very special guest. He may have a very familiar face because he's a well-known speaker and a topic expert on this high-quality cancer care subject. And I'm going to ask Drew to advance us to the next slide so I can go over some highlights for today's talk. As you know, I always begin these advocacy chats by sharing some highlights of what's happening at COA and CPAN. And exciting news for us is next week, we're excited to see many of you at our conference, March 17th through 18th at the Gaylord's Palm Resort in Florida. For reasons that we all know all too well, this is our first live event since the COVID shutdown. So our enthusiasm is very high. And speaking of enthusiasm, we have off the chart registration. So we're very excited to see everyone. But I also wanted to take this time to thank all of you who continued to support COA and CPAN as we transition to virtual events. Your participation through these virtual events has meant so much to us. And as we go forward in this new COVID world, post-COVID world, we're going to be offering live events, but you can also expect to see more virtual events and hybrid events, which gives us the opportunity to reach more of you with our messages. So again, thank you so much for your continued support. I do have some leadership updates. As many of you, or some of you may know, I'm joined in my leadership role by two practicing medical oncologists. Dr. Miriam Atkins is known to many of you, and she is a practicing medical oncologist at Augusta Oncology. And I'm thrilled that she has served for many, many years as our CPAN medical co-chair. And she also serves as the COA vice president. I want to thank Dr. Lakshmi Agrawal, who is from Fort Wayne, Indiana, who served as our CPAN medical co-chair for many years as well. Not quite as long as Dr. Atkins, but she worked just as hard. She is moving on to focus on other advocacy initiatives, and I want to thank her for all of her time. I'm really excited about welcoming Dr. Harsha Vias from Cancer Center of Middle Georgia. And now I had the opportunity to visit his cancer center when we did a CPAN launch event. And yes, he has a lot of fun making sure that people understand that there really is a place called Dublin in the middle of central Georgia. Well, it was just an incredible experience for me. And I was accompanied by a wonderful advocate from Georgia, Lynn Loback. That's another story. She was my local tour guide. But I was so impressed by visiting his cancer center, again, in the middle of Georgia. This is one of the most sophisticated cancer centers I've seen. And it just really proves the point that community, as you all know, community cancer clinics, which are independently owned by physicians, exist in places like Dublin, Georgia, which can be a single site location, or some of our big practices like Texas Oncology or Florida Cancer Specialists. So whether a patient is being treated at a single site location in the middle of Georgia, rural Georgia, or a big sophisticated cancer center, you can be totally confident that that patient is going to be receiving high quality cancer care. And that is what we're going to learn a lot about today. So our guest is Bo Gamble, who again is a topic expert. He worked for 12.5 years in a community oncology setting. And then COA was wise enough to spot his talent and brought him in the new role at that time of Director of Practice Initiatives. He has spent a career ensuring that patients and physicians are providing and receiving high quality care. Bo, thank you so much for being an incredible colleague to work with, such a person of such high character, so authentic. You're way too humble, I think, but you're incredible. And please go into professor mode and tell us exactly what high quality cancer care means. Thank you, Bo.
Thank you, Rose. I'm so thankful for you and your leadership and service to the community we love, the patients, and what they mean, the journeys they've been on, the stories they've told, and how it helps us make our world of cancer care delivery better. So thank you, Rose. Known Rose for almost 10 years now, I guess.
Yes.
So thankful for that. Just getting to know her and just her love for people and love for our team. So thank you, Rose. I had a depressing moment recently. I'm like, I got to thinking about it. I'm like, I just realized I've been in healthcare for 45 years. I'm really glad they let me start when I was 8, or I would not have been making it, because it's been way, way, way too long. And I must say that of all the initiatives that I've been involved in, got to see, participate, discuss, whatever, I'm very, very excited about this one and what it means to the cancer care system, what it means to the healthcare system. We're going to spend some time talking about that and what it means and how it relates to you guys and what you should be looking for in your cancer care from your care team and in your journey to making sure your cancer care is what it should be. And we want everybody to follow these guidelines. So Mr. Drew, next slide, please. By the way, I've asked Rose to keep an eye on the chat line for us. So you can feel free to ask questions all along the way. It's quite all right. I welcome it. You can go on, Drew. As Drew paints these questions on the screen, you guys have probably been asked some of these questions. I know I have been asked some of these questions. Sometimes you may be asking these questions like, how do we know, how do we really, really know what is good quality cancer care? And when I used to, I worked at a practice at one time, and just because I was in healthcare, people think you know everything. And sometimes I'd be out to eat dinner, and my wife, and someone says, "You work for so-and-so, what's wrong with my back?" I'm like, I have no idea. I'm like, I don't know what's wrong with your back. But we have these expectations, good about cancer care, but we don't necessarily know what good cancer care may be. You may be asking these questions, you may be asked these questions, but we see the same questions from everybody. Cancer care teams are saying, are we delivering quality cancer care? Insurance companies are saying, hey, I want to pay for quality. They make attempts of trying to understand what that is. Employers, everybody wants quality cancer care, but they can't really always define it. Sometimes we used to have a joke at my team, like, oh, why would you recommend our physician for your care? I love my doctor. Mm-hmm. I love my doctor. And love's important, but like it's got to go beyond the love and care. We've got to know the specifics of what to expect. So we're going to talk about how we tried to shape this journey. I want to make a clarification, or actually add some detail here. What we're going to be talking about are the care components for the entire journey, regarding what we call the oncology medical home. We're going to look at some components of those. We're going to talk about some of that in detail. To make sure that happens, we have another process we'll call the patient-centered cancer care. Get that, patient-centered certification process to validate, are these things being done as expected? And that's going to be very important. We're going to be talking about the components and some of the detail. That is, we won't be public knowledge. We're going to rent some billboards. We're going to put them on the highway. Everybody needs to be looking for these things in this cancer care process, because we want everybody to provide high quality cancer care. Mr. Drew, next slide. In its simplest form, this is what the oncology medical home contains. There's 7 components. You can see at the center, and most importantly at the center, is patient-centered cancer care. All 7 components should focus around, should work around, should have everything at its base of priorities, the patient. And if it's not in the base, you need to rethink that process, because we need to keep it at the patient base. We're going to talk briefly through those. The first 6 of those, starting with patient engagement, happens to be very specific about the beginning and end points of the care. The chemotherapy safety, that got added okay, let's do this as a value added aspect of the program, making sure that chemotherapy is provided in a safe, consistent environment for the patients, for the staff, and everybody's following the same criteria. Within these 7 components, the first 6, will be 18 specific criteria that we're going to look for. I'm going to talk about some of those, not in total detail, but I'll talk about those. So here's what was expected when we say patient engagement. Likewise, access to care. Likewise, evidence-based care. We're going to get into what exactly does that mean. I'm not going to get into all the detail because we don't have all afternoon. But I'm going to share some of this so that you can see what we're expecting. And this is for everybody. Although Rose and I are very committed to and are champions for community-based cancer care, the logic is everybody needs to be following these criteria. Everybody. It should make really no difference to quality. We're going to raise the bar or create the bar, or the view, the perspective that everybody, every cancer patient, everybody that finances or supports cancer care needs to look for this criteria.
So that's something that we're going to share in detail. Next slide, Mr. Drew. We mentioned patient-centered. Let's go back to patient engagement. There you go. They got to go quickly. I want to spend a few minutes exactly what that means. There are very specific communications that need to happen when you're first diagnosed. One is, you're very probably frightened, you're very concerned, you're very worried. So at that time, it's very important to have very specific communications. One of which would be, let's talk about your plan. Here's some things you need to here's what we're going to talk about. Here's how it could impact your schedule, your family, whatever. Here are some tests that we're going to run along the way. Pretty much a very personalized, detailed treatment plan once you've had those initial discussions about your journey and what to expect. One of the big concerns that we are all talking about, and Rose and I, we are attending many calls in a week's time saying cancer care, particularly the cost of drugs, is getting crazy expensive. What are we doing to fix that? In those discussions, early in that process, will be a discussion saying, okay, let's talk about it. There will be a requirement by the team that says, okay, here's what's planned for your care. And based off what information you shared with us, here's what you can expect to happen to your budget. Now, let's talk about how can we help you with those budget issues, whether it's drug assistance through programs, foundational money, whatever. But you do not need to go through that journey with the burden of feeling financial, what they call financial toxicity or financial weight going in this process when all you're trying to do is take care of yourself or your family. That's number two. Now, the other thing that has to happen on the side of the patient engagement piece is like not just the care plan of care. Okay, suppose what happens when your treatment's over? And let's say you got a really good bill of health, you're cured or whatever, you may be thinking, now what? In discussions with Rose, there is oftentimes that concern, well, the practice, patients did not want to miss a single treatment because they thought that treatment might have been the magic pill, the magic moment where you were completely healed. But then when you're healed and when you get a clean bend, the tumor's gone, whatever, and you feel good, you got to go, now what? And there's this little bit of like insecurity of like, what about my team? What about my support structure, whatever? They're included in this patient engagement is communication and instructions of how to stay engaged with you and your care after that process, which is very important. When do you need to have some double checks, make sure everything's okay? When are you going to come see us? When are you going to come hug our neck? We need to hug you too. Keep that process going for that continuing engagement. Someone described to me best that there is really, and I think it's a very good way of looking at it, the patient engagement piece of this program, the Oncology Medical Home, is really the heart of the trust. And that is assuring that the care team is proving worthy of your trust. And there's also communication saying, okay, how can we work together to make sure your journey is possible? Now, the other thing that happens along the way is making sure the team knows what they can expect from the team as far as the care and how to reach it again, how and some of the expectations they should anticipate through the care journey. And we're going to get into some of those details so you can know exactly what I'm talking about. And if you're in a journey, you're like, wow, they didn't say this to me. Maybe I need to ask that question because it's important. Patient engagement is where we would start. That's the process. Building that trust. I mean, by the way, it may not always be your physician. It may be someone who's really gifted with the communication, the kindness, the skills to say, hey, let's just talk a few minutes about what's going to happen here and where you are along the way. And that's okay. The second one, Mr. Drew, availability and access to care, is very important. If you've read any of the research and seen the papers, and Rose and I see them often, how expensive the emergency rooms are, how expensive hospitalization is, and how disruptive it is, and how cautious they are. Someone comes and they go, oh, wow, we we needed to run this test, this test. And pretty soon it's like crazy expensive. The availability and access to care is assurance provided from the care team to the patient, like, we are here for you 24 hours a day, 7 days a week, 365 days. We may not be in the building, but here is a way to access us so that it happens very smoothly. You get access to us. And suppose you're sick in the middle of the night, call them. How do you do that? And we challenge the teams that says making sure those processes is as efficient as possible. There's no sort of hiccups in the way. Let me share an example with you. And it's a little bit related to another standard on the way. We're on access to care. And by the way, the access to care says let's minimize unnecessary hospitalizations, ER visits, and let's also, as you go to the emergency room, let's study why are patients going there. And if they happen to be hospitalized for whatever reason, we challenge that team to make sure there's contact with that patient soon thereafter. So there's a smooth transition of care from the hospital to the care team, make sure it happens. Well, let me share a real example of why that's important. Some of you guys may be aware that there was Medicare had this model what they called the oncology care model. It's very different care delivery system, had different payment pieces to it, whatever. And they asked for certain things to happen. In exchange for that, they started measuring, okay, how well are you doing minimizing unnecessary ER visits and hospitalizations, whatever. One of our physician friends in Texas, they are like got their information, says, here's how you're doing. And it wasn't necessarily good. In fact, it looked pretty bad as far as ER visits. So they put their heads together. They had the team meetings. They had the chalkboards, whiteboards. They had all these plans. And we said, okay, here's how we're going to address it. They tried to address it. They didn't get any better. And they go, oh, this doesn't make sense. They were frustrated. Come to find out, as regards to access to care, the emphasis, call us first. What was happening is the patients were hearing the message. They would get sick in the middle of the night or the weekends. They wanted to call the practice first. Well, but lo and behold, what they got involved in was this complicated, ridiculously silly phone tree. Hit 9 if it's a Tuesday, hit if you're like, whatever, your eyes are blue, hit this. And they go, forget this. I'm not going to talk to my team. I'm going to go to the emergency room.
Right.
Once they realize that, they go, we made it too complicated. They got rid of the phone triage system. They had real people answer the phone. They anticipated those needs much better. The emphasis in this area is making sure that team is available 24/7, regardless of the day. They're there for you, and it's there for you in every way. And if by chance you're seeing ER visits, why are you seeing them? And if you're seeing hospitalizations, are you transitioning to them? Well, the next one. Let's talk about evidence-based medicine. I love to talk about this. As we're seeing in some of the things CO has done along the way, and particularly in the last several years, we are seeing that sometimes, sadly, insurance companies are not fully aligned with what the care needs are for patients. Nor are they sometimes aligned with the care needs of providers trying to do for their patients. Sometimes they place obstacles in the way. There's oftentimes a confusion between what some call a formulary, meaning a preferred list of medications, and a list of evidence-based medicines. Within this component, there are two areas that we try to focus on. One is for any given disease, any given treatment of the disease, and supportive therapy for those diseases, what does the evidence say is most effective? Not what the physician always thinks, although they have some great creative ideas, but like, what does the evidence say will work in this situation, given maybe the cancer or maybe some other conditions that the patient may have? And there's evidence out there just about in all cases, making sure the care team, the physician, is abiding by that evidence. Now, there may be deviation, and we're asking, okay, if there's deviation, explain yourself. Why did you deviate from the evidence? We need to know that. And if there's a trend, then maybe we need to research more evidence to make that better. Now, Rose, I share her passion and enthusiasm for clinical trials. Clinical trials fits in this areas also. And the component does not say you must absolutely offer clinical trials, all of them, whether it be National Cancer Institute or drug therapy, whatever. It's not that you have to offer them, but you must make them available. And if your team does not have them available, you provide easy access to someone that does. Now, Rose mentioned the team I was on at the time. I was in a rural setting. We had 5 locations, 7 physicians, but we were very country folks, and we knew everybody, and we knew everybody came in the door, whatever. However, our lead physician was probably the nation's champion on clinical trials. We made it difficult for our physicians to not offer clinical trial, make it easy for them to offer clinical trial. And because we thought it was, and continue to think, it's state-of-the-art medicine. How do good therapies get out there except for clinical trials? That's how they get out there. So we're requiring that process to make sure that the treatments are evidence-based. What evidence supports your decisions to treat this way for this patient? And likewise, what clinical trials are being made available to the patient? And by the way, let me make a note here too. There's some that are like skeptical or like about clinical trials. Having seen the management support and care for patients that are in a clinical trial, I would argue that the care is 2 to 3 times as intense and personal. Yes. More phone calls, more checking-ins, more visits, less costs, probably, most cases. It's a better care. So I'm a big fan of clinical trials. Next slide. Equitable and team-based care. This one is a tough one. And it kind of goes all over the place here. You go, what is equitable care? Well, it really means are patients giving access to care for all the care needs they may have, in addition to the cancer care. And that kind of goes a long way. And also team-based. If you've been involved in any kind of organization, whether it be Cub Scouts or bridge clubs or golf teams, whatever, it's really hard for you to do things well without some sort of team leader. This component of the Oncology Home requires there must be a leader. And that leader must direct and coordinate the care internally, externally. They are the police. They're making sure it happens. If it doesn't happen, they've got the staff to make sure it happens. And by the way, it needs to be equitable too. And that means that if you think about it, and as we learn more and more, there are lots of, sad to say, there's prejudices, there's gaps between understanding of what care is and the need of that and how it fits. Let me give you a for real example. One of our physician friends in New Mexico, we love her dearly. She serves on our board, has been a champion for a long, long time. Serves in an area where there's Indian reservations. From an equitable disparity standpoint, that says, we really need to get out there and do some breast cancer screening because these patients, they don't trust us. We need to go out to their community and offer this service to see how they are. Sounded like a great idea. Let me tell you what happened. They purchased a van for breast cancer screening. They went to the Indian reservation to offer them, and they had very little participation. You go, why is that? And well, our minds can't understand that. Well, what happened was the people were there, the people in the village were there, and it says, what's going on? It says, do not go in that van. If you go in that van, you're going to get breast cancer. That was the mindset that they had. So, we go, wow, what other mindsets are out there that are preventing care, access to care? Is it transportation? Is it food? Is it whatever it is that's impacting that family that also impacts their care, their journey? What can we do to help? Said another way, if you're a cancer care team, your responsibility goes far, far beyond just the tumor. And that's a requirement. And we want to make sure the whole patient, the family, whatever is taken care of. visited a cancer practice in a nearby state. Their number one issue was transportation. They were in a rural setting. Patients were, you've seen the movie Plane, Trains, and Automobiles. Imagine something similar, just trying to get to the oncologist office. We have got to do something to fix this. Identifying and addressing those needs. And whatever that may be, take an inventory of the issues they're having, then coming up with solutions along the way. Equitable and team-based care is very, very important. Making sure the support services are in place.
I want to add something to that. You just triggered a memory when you're talking about equitable care, and it also ties into cultural competency. Years ago, when I was involved in breast cancer advocacy specifically, in southeastern Connecticut, I was doing some volunteer work for a public health department. And we also had brought out a mammography van to basically an adult education center. And prior events, there was always a lot of women that had signed up to get to get on the van, the mammography van. But this time the driver of the van was a male, and he had just like a lawn chair just seated out somewhere in the area near the van. Well, nobody was signing up, and we couldn't figure out why. And it turned out that these women thought that this male driver, who just happened to be sitting out there, was somehow affiliated. And many of them came from many different multi-ethnic cultural backgrounds. And they incorrectly assumed that, oh, this man is somehow going to possibly see me partially disrobed. And it was just a really big lesson about, again, talking to the community that you're serving. And I think the example of the Indian reservations in the Southwest, a lot of knowledge was gained by that experience, which we know Dr. McEnany has shared with many of us. So thank you for sharing that story.
Sure. And when you think about how much other things do we need to be aware of that we just don't know yet.
Right.
And we do not know that until we get to know our patients and the communities in which they live. I'm good gracious, I'm running a little behind, but that's okay. Quality improvement, one of my favorite topics. It is not enough, cancer care team, that you do these things well when somebody comes to visit you on that day. You're required to demonstrate on an ongoing basis compliance to this criteria, these expectations in every way. In addition to that, you must pursue, study, respond to, and address patient feedback. You must. That's a requirement. We recommend several type surveys for that. Funny little story is that you also have to be able to share feedback at the physician level. That does not always go over so well. I'll share a funny story. COA has a patient survey that it's not the prettiest one in the world, but it works really well. It's also free, which we love, practices love. And the team that first kind of helped test it, this was been 8-9 years ago, said, we love your report. However, when we share the fact that we're not doing well in these areas at our board meeting of physicians, they kind of like, you're not talking to me. You must be talking to somebody else, because that is not me. We ended up adding a report or a function, a detail of that report says, oh, by the way, here's how we're scoring by physician. The story, as the story goes, we just plopped it down on the table and it was game on. What are you doing different than me, than I am? And so it really helped increase that area. So patient feedback, and each team must identify, address, show improvement on at least one quality improvement project every 6 months. You cannot rest in this business. You need to make sure you are pursuing higher and higher quality with every turn. Quality improvement is a product. And that's like, hey, don't just like, let's not check the box. We had a meeting, we talked about how we want to improve. What'd you do? Show us how you improve. Probably the number one item that is on my list that I think very much about, and for personal reasons as well as other, and that's the next item, goals of care, palliative, end of life care discussions. That ranges from the legal aspects of making sure you have an advance directive to a very heartfelt, comprehensive discussion about honest discussions. We've explored all the known therapies. They've not worked as we wanted them to. what would you like for us to do? And how would you like to spend your last days with your family? Having that discussion, sometimes it's okay to stop the treatment. Sometimes it's best to say, okay, my last wishes were to be with my family in my home, on my porch. All I ask is that you keep me comfortable, period. And how are we supporting that? What we're seeing, those discussions sometimes are very, very hard to do. I will also share that physicians are not always trained to think that way. They are trained to say, hope, 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 and they may try the treatment up until your last day because that's what they were trained to do. And we're trying to say, well, maybe there's another option, and that is to balance that hope with what is best, what that patient wishes. We've also seen situations where the patient and the family may not always agree on what those wishes are. How can we facilitate this discussions to making sure that happens? That is a very, very key part of that program. I have seen what happens when that discussion does not happen and the patient passes in a hospital, no preparation, and the family still dealing with the grief and burden of the unknown. So I'm a big, big, big fan. To top it off, we go, well, chemotherapy safety. There are 22 standards within that component of the oncology medical home. Very, very detailed, having to do with validation, double validation, processing for different drugs along the way, sterile rooms, non-sterile rooms, whatever, making sure that the treatment you get is as safe as possible and is everybody's working from the same guidelines. That's an important part. Now, the organization that we're working with this, you may not have heard of them, is the American Society of Clinical Oncology. They have a tremendous history in this area, both in this country and abroad. I think there are 300 cancer care teams that have been certified in this area. And I think 8 different sites in other countries. They're very well equipped for this, and they have become our partners in not only, I guess, making sure the details of this criteria is done, but also validating that it's done and proving that it's done with measures. So we're working with them to promote this program. And guys, I think it's probably the most meaningful, appropriate program that I've ever seen in the cancer care system, the healthcare system. So where are we in that process? Mr. Drew. Next slide, please. Okay. I've had the honor and privilege of visiting half of these sites. These are 12 teams that committed to says, we want to do this. We see that's important. We will prove to you that we did, and we'll do, and they'll win at it. Well, I went to see 6 of them in the effort, and I can tell you, this criteria is not as easy as it may look. We did not see any of the 12 that hit all the criteria on the first visit. And when I say visit, this was an all-day discussion with their care team, members of their care team for different components, talking about aspects of this program and how well they're doing. The purpose of the discussion was coaching, guidance, support, understanding that criteria and putting in the processes, team members, touch of love and kindness to help along the way so that they could get to that point. Right now, if you look at this list, there were 8 community teams, 2 universities, and 2 hospitals. We don't care. We want these standards to apply to everybody. They will submit their final criteria into May. After that, then we hope to roll out this program to everyone in the country. We're currently trying to educate insurance companies that you need to be looking for these things. And by the way, employers, here's some ideas to help you with adjustments to your insurance benefits to make sure it happens. Let me give you a classic example. And this came up often, sadly. The end of life care discussion, the most honest, important discussion that may happen in some's journey. Patients, although it's incredibly important and it can present value in many different ways, Some patients resisted it because they, quote, did not want to pay for another visit. I'm like, oh, simple solution. If you're designing benefits and you're trying to help your patients, your beneficiaries, remove the patient out of pocket for that visit. It is that important. Make it easy for them to do the right thing. So this program is leading to all types of improvements in the cancer care system, and it's being very well received by employers, payers, employer coalitions, anybody that understands it. We hope that patients pick up the facts as, oh, where's my treatment plan? Who do I call after hours? I don't want to go to the hospital. Who do I call? And by the way, are you giving me evidence-based medicine, or is it just something you think you need to do? Pretty much being very transparent and being very positive and quality focused in everything they're doing. I'm excited about this program and what it can mean and for everybody. Questions? Anything in the chat, Ms. Rose?
I don't see anything in the chat, Bo, but I do. I'm pretty confident that the audience probably had a lot of the same sentiments that I did. And that's, thank you for painting this picture about what quality cancer care means. In your opening comments, you talk about how, sometimes as patients, we define a physician's competence by their personality. Like, oh, I clicked with them. Are they nice? You feel good about them. But now you've given us food for thought about what are the different components that is actually quality cancer care. It's not just if my doctor's a nice person, and my doctor's not a bad doctor because they didn't knock on the door first, even though that does get me mad if they don't knock. That's my own bias. It's a quick tap. But also, I think something that really stands out too for me, Bo, is the end of life discussions.
Yeah.
Because again, for the doc, you and I, we work with doctors and nurses, oncologists, nurses, pharmacists, and they're doing such great work. And when they have good news, it's easy for them to deliver that because we all like good news. And in the advocacy world, we like to talk about good news, survivorship, survivorship, survivorship. And I'm glad to be a long-term survivor, but sadly, there is still cancer deaths every single day. And when there are no treatment options, knowing that your oncologist, your nurse, or as you said, someone else on the team can deliver you that news, that truth that patients need, even if it does make you incredibly sad that you're not going to survive. It is an obligation of the physician to provide that to us. And I hope I'm never in that situation, but any cancer survivor may be. So I think the work that you're leading and have been doing for a very long time, like you said, you must have started in childhood, but thank you for all the great work, Bo. Really appreciate it. And if we have any questions after this, we'll pass them your way. So is there any last things you'd like to share before we go on to the last slide?
I'm thankful for you, Rose. I'm thankful for your network. Thank you that you guys really give us the definition. Rose and I have often said, this is not a job, it's our mission. Our mission is to help the world you're in, help this improve it for others to follow, and to do the right thing, always do the right thing with regards to patients. So thank you for the opportunity. I look forward to talking in the future, and I wish you all very well.
Okay, thank you. And last slide, Drew. Oh, we have one more slide. And again, thank you to the audience for joining us. We really couldn't do this without you. We love knowing that you're out there. Next month, we have Alan Bach, from the Chief Executive Officer from the Patient Advocate Foundation. He's also extremely well known, and you can see from his big smile, he's kind of like Bo. He's just truly who you see on screen is who he is in person. He's extremely knowledgeable, and we're going to be talking about health equity, which is one of the topics that Bo addressed today. So thank you, and we'll either see you in Florida next month, or both places, in Florida next month and back here in April as well. Thank you. Have a great day.
Thanks, guys.